It started. Hello everyone, happy evening. Welcome to another episode of C3 with N3 with your mentor Dr. Nikita Nawani. And this is your second part of your most expected topics. Apart from this, I've taken your 5 sessions in special classes on the most expected questions for INI-CET. Make sure you have watched all of this. If you missed those, you can still watch them on the Unacademy Learning app. Those are available to everyone. And apart from that, let me check the audio visual. Just give me a quick note whether the audio visual is all good. Thank you everyone. So apart from that, the big news is that we are also running the thank you everyone. So just okay. So you have another special class which is a free class for everyone tomorrow 4 to 6 p.m. I will be taking your fast track revision for INI-CET. That is 11th of November. Again, it's a free class and it would be mixed bag topics. I'm not disclosing the topics now. It would be surprise, but for sure very, very high yield and something that you can expect in your exam to come. Alright. Today's topic of discussion, I'm sure you all must be eager and excited to know what the topic is for today. It is simplifying your topic of your platelet disorders. Okay? Platelet disorders, of course, we are not seeing everything. But the most important ones, the Bernard-Solier, your Glanzmann's and the von Willebrand disease, we will simplify that table and we see some questions which are asked on those topics. Alright? No, Rachel. This is a very, very short session, maybe just half an hour session that we are going to have. Alright. So as I said, please make a note. This is your fast track revision for INI-CET tomorrow 4 p.m. to 6 p.m. It's a free live class for everyone. So make sure you do not miss on this. And apart from that, today we had the GT analysis discussion at 5 p.m. And tomorrow, the Plus subscribers, we will be starting with CVS Radiology. Right, we'll be starting with CVS Radiology. So as you all know, I am a radiologist with medical mnemonist. So I cater to radiology plus the mnemonics and concepts for other subjects. So 12 to 2, we would be having CVS. So the plan for tomorrow is CVS Radiology tomorrow. It's not tomorrow, it's day after, right? It's on 12th. Tomorrow you will have 4 to 6 class and you will have again the YouTube live session at 8 p.m. And on 12th, you will have CVS Radiology. Plus, I have taken Radiology revision in the Plus course. There are other courses, the WAVE, which is dedicated image-based course running platform, and the previous year questions for NEET PG 2021, which is running on the Plus platform. So I hope all of you know the referral code, the coupon code to use for subscription. That is Dr. Nikita. Alright. So let's start with our today's class, which I told you is about simplifying this table of Bernard-Solier, Glanzmann's and von Willebrand disease. I am sure many of you would be afraid of this huge table. Let me know if it's one of those scary tables for you. And hopefully I'll simplify this for all of you. By the end of the session, all of you would have mastered this table. So we'll come back to this table. Before that, let us understand some concepts in your basically how a thrombus is formed. So thrombus is formed, when there is a vessel injury. When there is vessel injury, so your von Willebrand factor, it is exposed on the endothelium. From where is it released? It comes from your endothelium. Which bodies in the endothelium release your von Willebrand factor? Your Weibel-Palade bodies, right? Weibel-Palade bodies, those are the ones which secrete your von Willebrand factor once there is a vessel injury. Now, when this factor is exposed, so you have platelets coming into this von Willebrand factor. On the platelets, you have this receptor which is GP1B. You have GP1B which binds to your von Willebrand factor. So you can see that this one has a role in platelet adhesion. This one has a role in platelet adhesion. Now once that platelet gets adhered, then you want to build up more platelets on that so that there is platelet aggregation, and that is what forms your thrombus then. So once is your platelet adhesion, then once it is adhered, you have your ADP, which induces the conformational change into the platelets. So that is why ADP has a role in platelet aggregation. What does it do? It induces conformational change. Basically, the platelet size decreases, and your aggregation receptor, which is your GP2B3A, it comes on the surface of the platelet. This GP2B3A is the one which binds to fibrinogen. And this fibrinogen then links the various platelets, and that is how platelet aggregation takes place. Right? So if I have to quickly revise with all of you. So the first thing in your thrombus formation is your endothelial injury. You have von Willebrand factor coming. To it binds your GP1B9, which is basically platelet adhesion. After platelet adhesion, you want platelet aggregation, which is GP2B3A. This comes on the surface by the action of ADP. So ADP causes this to come on the surface. This binds with fibrinogen, plus it binds to other GP2B3A receptors on platelets. That is how all the platelets get clumped together and you get platelet aggregation. Right? So to remember this easily, which is the receptor for adhesion? Because adhesion comes before aggregation, it is GP1. It is GP1B. So for adhesion, it is GP1. For aggregation, after number 1 comes 2 and 3. So it is GP2B3A. So 2B3A is for aggregation. So when we say that there is platelet adhesion defect disorder, basically there is problem in GP1B receptor, and the disorder is your Bernard-Solier. While for aggregation, where there is GP2B3A defective, it is your Glanzmann's. It is your Glanzmann's thrombasthenia, which is your aggregation. So easy way to remember this is, adhesion is Bernard-Solier. It has D in it. Glanzmann is aggregation. Easy to remember. So adhesion is Bernard, AD. Aggregation is G, that is Glanzmann. Adhesion comes first, so it is GP1 receptor. 2, 3 come later, so aggregation ke liye it is 2, 3. Right? So that is what we see here. Absence or decreased expression of GP1B is Bernard-Solier. Inactive GP2B3A is your Glanzmann's. Okay, so Bernard would be adhesion defect, Glanzmann would be aggregation defect. And when you have a problem in von Willebrand factor, either there is decreased quantity or the quantity is normal but the quality is decreased. That means it is not functional. So there is deficiency or dysfunction of von Willebrand factor. That is what leads to your von Willebrand disease. Alright. So now, can you tell me this von Willebrand factor is also necessary for the action, for the function, proper function of which clotting factor? It is required for the proper function of which clotting factor? Clotting factor 5, 7, 8, 9, 10. Which clotting factor is it required for? Absolutely right, Sindhu. It is your clotting factor 8. It is required for clotting factor 8. Next question. This clotting factor 8, it is your clotting factor in your intrinsic pathway or extrinsic pathway of coagulation. It is the clotting factor in your intrinsic or extrinsic? Very good. It is your intrinsic pathway. It is in your intrinsic pathway. So when you have a problem in intrinsic pathway, what is the marker for intrinsic pathway? Is it prothrombin time or is it APTT time? What is the marker for intrinsic pathway? It is your APTT. So when you have von Willebrand disease, where von Willebrand factor is affected, so your clotting factor 8 will also be affected. So your intrinsic pathway will be affected. So your APTT will be prolonged. There will be increased APTT. While in your Bernard-Solier and Glanzmann's, because they are like pure platelet disorders, nothing to do with the clotting factors. So you will see bleeding time BT which is increased in these disorders. So whenever you say BT increased, BT tells you that it is your platelet disorder. So in your platelet disorders, you have BT which is increased. So all the three which we mentioned, von Willebrand disease because platelet adhesion is gone, Bernard-Solier because platelet adhesion gone, Glanzmann because platelet aggregation gone, all of them will have bleeding time prolonged. Apart from that, von Willebrand will have increased APTT. While here you will have both PT, APTT, the clotting studies will be normal. Your APTT will be prolonged, PT will be normal because prothrombin time is extrinsic or common pathway, which is not for factor 8. Alright. So that is about these disorders. Now another easy way to remember to include your von Willebrand disease. Bernard is adhesion. Von Willebrand when you write, that is also your AD. So that is also adhesion disorder. Bernard is also adhesion disorder. So both of these are adhesion disorder. Glanzmann is aggregation disorder. Now coming to your table which we mentioned. So very important, and we'll quickly summarize this. What is the inheritance pattern of each of these? Now, we have had one amazing session on inheritance patterns. I hope all of you have watched that in the plus session. Like we had story mnemonics for autosomal dominant, recessive, X-linked, recessive and dominant. So if you remember in that inheritance pattern story, we mentioned about von Willebrand disease, which was that story of a fight between the taxi driver and all. So von Willebrand we have seen was autosomal dominant. It was autosomal dominant. Alright. So this is autosomal dominant, most common inheritance pattern. There could be others also, but the most common is autosomal dominant. These two are autosomal recessive. Bernard and Glanzmann, these are your autosomal recessive. What is the defect in your Bernard-Solier? It is platelet adhesion. Glanzmann is platelet aggregation. Von Willebrand is again adhesion plus your factor 8 which is gone. Okay? Mechanism is your GP1B9 basically which is gone. Glanzmann mein it is GP2B3A. Von Willebrand you have three types. You have type 1, type 2 and type 3. So in type 1 and type 3, these are the two types where the quantity is affected. Type 2 is the one where the quality is affected of your von Willebrand factor. Okay? Now, platelet count. Platelet count can be normal in all of these. It can be normal in all of these. There can be mild thrombocytopenia in your Bernard-Solier or in your von Willebrand disease type 2B. There can be decreased platelet count. Okay? So basically your adhesion wale mein you can get a decreased platelet count or it can be normal also. Platelet morphology. Where is the platelet morphology affected? Bernard-Solier. You have giant platelets. Very frequently asked question. You have large platelets with dense bodies. What is the function of these dense bodies? It releases ADP. ADP causes conformational change. It decreases the size of platelets. Since that is not happening here, your platelets will become large in size because aggregation is not taking place. The conformation change is not happening. That is why. So you get giant platelets in Bernard-Solier. So the name itself is giant. You have Bernard-Solier, a giant name. It has giant platelets. Here the platelet morphology is normal. Can you tell me where do you get microplatelets? Small platelets. Frequently asked question asked in recent NEET PG. It is your Wiskott-Aldrich syndrome. Very important. Wiskott-Aldrich syndrome has small platelets, microplatelets. Next one, bleeding time. We all said these all are your platelet disorders. So bleeding time will increase in all of these. PT, APTT. PT, APTT markers of your coagulation factors, the clotting pathway. Normal in Bernard-Solier, normal in Glanzmann. In von Willebrand, because of factor 8, it is your APTT which is increased. PT is normal, intrinsic pathway affected. This one, your ristocetin test, which is also called RIPA test, ristocetin induced platelet aggregation. Even though the term says it is platelet aggregation, but remember it's basically a test for platelet adhesion. It is a test for platelet adhesion. So thinking logically, if it's platelet adhesion, it would be abnormal in conditions where your platelet adhesion is abnormal, right? So basically it would be abnormal in your Bernard and in your von Willebrand disease. So these two will have abnormal ristocetin test. Glanzmann has normal. It has a normal ristocetin test. Now which one normalizes after giving serum and which one does not normalize after giving serum? So now your ristocetin test, as we said, basically it's for platelet adhesion. So abnormal in your Bernard-Soulier and in your von Willebrand disease. So after giving serum, it normalizes in your von Willebrand disease. So normal after giving serum. Why? Because your serum will provide the deficient levels of von Willebrand factor. Serum will have von Willebrand factor. So basically you are giving external from outside von Willebrand factor. So it will normalize. So if it normalizes there, this does not normalize after giving serum. This does not normalize. Because here the defect is in your receptor GP1B9. Okay? So normalizes after serum with your von Willebrand disease. This does not normalize. This does not normalize. Then von Willebrand levels, very easy to understand. It would be decreased in your von Willebrand disease and in the rest of them it would be normal. Bernard-Soulier, Glanzmann, it would be normal. Apart from that, you have decreased factor 8 as well in your von Willebrand disease, right? So you can see that we have very easily and conveniently simplified this table, and which initially seems very difficult, but actually it is very easy to understand once you know the concepts. What is BT, APTT, factor 8, adhesion and aggregation, right? And since we saw the role of your ADP in your platelet aggregation, we said it causes conformational change. So the drugs which will act on ADP receptor, the drug which acts on your ADP receptor, P2Y12 receptors, they would be your anti-clotting. Okay? They will prevent the thrombus formation. Which are those drugs? So you have clopidogrel, you have ticlopidin, prasugrel, all of these, they act on ADP receptors. And that is how these drugs, they act as antithrombotic. They do not allow the thrombus to be formed. Right? Now, let us see some questions. I am sure all of you will get this now. It is very easy to understand now. A disease of defect in platelet adhesion with abnormally large platelets and lack of platelet surface glycoprotein is your, whenever you see abnormally large platelets, your giant platelets, giant name, Bernard-Soulier. Absolutely right, it is Bernard-Soulier. Glanzmann is a defect in aggregation. Von Willebrand is a defect in your adhesion. Okay? Next one, you can see it was asked in the year 2014-15. Von Willebrand disease is usually inherited as, autosomal dominant. Your Bernard and Glanzmann, they are your autosomal recessive. They are autosomal recessive. Can someone tell me the chromosome number for von Willebrand disease? Chromosome number for von Willebrand disease? Chromosome 6, no Bala? No. Anyone? It is chromosome 12. It is chromosome 12. Again, we have discussed the genes and the chromosome numbers with all the mnemonics in your class. Please make sure you watch those both sessions, inheritance pattern and genes and chromosomes. Alright, it is chromosome 12. Next one, The coagulation profile in a 13-year-old girl with menorrhagia having von Willebrand disease, what would be the coagulation profile? Yes, Prasanna, I'll share the links in the group so that you can conveniently watch those sessions. Yes, it is A because von Willebrand disease, factor 8 is gone, intrinsic pathway, APTT will be prolonged, PT will be normal. So you have isolated prolonged PTT with a normal PT, right? Okay, so that was the last question. There are a few other questions which I have discussed on this topic in the Plus class. I'll share the link of that as well. So I'll share the links of 3 sessions in the Plus class, which is your inheritance pattern, which is your genes and chromosomes, and this topic where I've discussed more previously asked MCQs on this topic of platelet disorders. Alright. And in the description, we have also shared the links of these special classes, the free classes that I have taken on your most expected questions for INI-CET. There are 5 sessions. Each of these is very, very high yield for your exam. Make sure you have watched those before your exam. And so please remember, I'll see you tomorrow at 4 p.m. with your special class. All you need to do is download the Unacademy app. It's a free class. Go to the NEET PG Gold, and in the special classes, you'll see my class. I'll be there at 4 p.m. from 4 to 6 p.m. And if at all you're interested in watching the other classes that we have in the Plus subscription, my classes plus other educators, you can choose for either Unacademy Plus or the Iconic subscription, which is with Unacademy. That is your Iconic subscription, Unacademy and Prep Ladder. You get both in one subscription. And the referral code you all know is Dr. Nikita, right? And also attend the daily live quizzes, again free for everyone. It's a live test. You get live leaderboard at 8 p.m. and at 9 p.m. right? And that's all for today, guys. I hope you have enjoyed this session. Revise it, make notes, solve questions, and you are done, forever with this topic. All right. So, yes, Arun, I'll share the links of the inheritance pattern and the chromosomes as I said. Okay. And Rahul, the topic for tomorrow, as I said, it's a mixed bag from radiology, of course, and from other subjects as well. Whatever is what my instinct says will come in your exam, that is what I would be discussing tomorrow. And many times my instinct does work. So, dermatomes, flawless it's me. We have discussed the dermatomes in the Plus class recently with the mnemonics. The easy way to remember the dermatomes, right? And Apla syndrome, Anjali, if you want, we'll discuss it tomorrow in the special class. Okay? Yes. So, Asha, what is your query? Maybe I missed your query. What is your query? Yes, Asha, I'll share the link of these sessions on the Telegram group. I'll do that definitely. Okay? So, I'll see you tomorrow at 4 p.m. from 4 to 6 and on YouTube live session again at 8 p.m. So, till then, goodbye, take care, keep studying, keep revising and keep winning, and good night.